all. Today we are going to have a case-based learning session on drugs affecting the autonomic nervous system. Now, what we have found with you people, that is undergraduates, is that though we teach you all these topics during your regular classes on autonomic nervous system, when we give you all the exercises in the exam, that is, we give you all hypothetical cases and you are supposed to correlate your theoretical knowledge with clinical medicine, and you are supposed to be answering those the questions to those hypothetical scenarios. But unfortunately, we have found that students are unable to do so. So we thought that maybe we should have for every batch of undergraduates a teaching session where we give them clinical scenarios similar to what we give in the exam, so that it will sensitize them and it will get them used to applying their knowledge of theory which we have taught them during the classes on autonomic nervous system, that knowledge, so that they should be able to correlate it to the scenario which has been provided to them. So if they do this during their small group teaching sessions, case-based learning sessions, we take it that they will be effectively, be able to give answers to the scenarios which are given to them during their sessional and university exams. Okay, so with that background, as I said, the objective of my teaching session today, case-based learning session, is that at the end of this learning session, all of you, that is phase 2 MBBS students, should be able to apply their knowledge of drugs acting on the autonomic nervous system to analyze hypothetical clinical scenarios. So, to just reflect on what we have already learned till now, in your theory classes, we have finished the whole of the autonomic nervous system, that is drugs acting on the cholinergic system, the agonists and blockers, as well as drugs acting on the sympathetic nervous system, the agonists as well as the blockers. Now, we have finished theory classes, and in addition to that, 1 week ago I had given you all some resources which you can refer to for drugs acting on the autonomic nervous system. So I take it that in 1 week you have gone through the resources, and I had also shared with you the PowerPoint presentations which we had projected during our lecture. So with all that, I take it that now you have come prepared, okay, and that you will be able to answer the scenarios which I am going to be giving to you all. So you please take these scenarios, and I will give you all time. You are supposed to discuss with your peers. Okay, so time will be given. I will give you all 2 minutes. Okay, and in this time we have 2 scenarios. So you can discuss this with your peers. Okay, and you are also free, if you want to use your digital resources, that is your smartphones, you can use, and you can think of what are the answers to these questions. So I will just read out the first question. Okay, what I will do is, after this I will give you 1 minute, or okay, I will give you 2 minutes for the first question. We will discuss that, and then we will go to the second question. So the first question is to do with noradrenaline. So here we can see that there is an elderly man who was given intravenous noradrenaline bitartrate 4 milligrams because he had presented with severe hypotension. Following this IV administration, he was given a maintenance dose by intramuscular administration, that is same noradrenaline was given. With his treatment, his BP shot up to 180 by 140 mmHg, and then gradually it touched the baseline of 140 by 100. Now on examination, it has been found that he has developed right-sided hemiplegia, and on the next day he has developed a gangrenous ulcer over the site of intramuscular injection. So after having gone through the case and after having discussed the case with your peers, you should be able to answer, and with the background knowledge that you have come with, You are supposed to be giving answers to these three questions. That is, what is the probable reason you think for his hemiplegia? What is the cause of the ulcer? So what is the cause of the hemiplegia? What is the cause of the ulcer? And how would you prevent such adverse effects in the future? So you can take 2 minutes, or before that also, if you are ready with the answer, you can tell me so that we can start with the discussion of the case. You all can discuss with each other. You can feel free to discuss. Everybody is ready, shall we start? Okay. So, what is the answer to the first question? So, Sagar, what do you think is the answer to the first question? That is, what is the probable reason for his hemiplegia?
Now it is because of cerebral hemorrhage.
Yes, very good. So, what has caused the cerebral hemorrhage? What is the reason for the hemorrhage?
Because of increased BP.
Yes, so the blood pressure, as all of you can see, it has shot up to 180 by 140. So this could have caused a cerebral hemorrhage resulting in right-sided hemiplegia. Very good, Sagar. Please sit. So Swarupa, now what do you think is the cause for his gangrenous ulcer?
Because of noradrenaline and vasoconstriction, so that vasoconstriction will cause ischemia and gangrene.
Okay, very good. So, yes. So, as we know, as she correctly said, the tissues at the site of injection, the vasculature which is supplying the tissues at the site of injection would have been suffering from vasoconstriction, and as a result, patient has developed gangrene over the site of the intravascular injection. So, the tissues have suffered from ischemia followed by necrosis, and patient has developed gangrene. So now, who wants to answer this question? That is, how do you prevent such adverse effects? Yeah, okay. Bala, you can tell us.
The main reason for this development of this gangrenous ulcer is extravasation.
Yes, very
So
good.
to prevent that, we can give for slow IV injection of oil.
Yeah, but here to say extravasation, so he has developed a gangrenous ulcer at the site of intravascular, not IV injection. So here my answer would be non-adrenaline, preferably we would go in for IV, not IM, because IM after giving the vasoconstriction of the tissues at the site of the IM injection has caused this. So avoid IM injection, please sit down. And as he has pointed out, that is one more, that is of course when you are giving intravenously, you have to be careful to see to it that the cannula is in the vein and there is no extravasation. Because sometimes what may happen is by giving through the vein, if the drug goes outside the vein, there is going to be extravasation of the capillaries there, and there is going to be again maybe at the site of IV administration formation of a similar ulcer and gangrene at that site. But here in this case he has developed ulcer at the site of IM injection. So best is for us to avoid IM injection and to go for an IV infusion of noradrenaline, basically IV. So that is what they have done. But how do we, the question still remains. So that is about avoiding gangrene. But what about avoiding the hemiplegia? What do you all have to say about that? That is one more major adverse effect. He has developed cerebral hemorrhage. So what is to be done about that? Yes, Sagar?
Monitoring BP regularly.
Yes, very good. You should not just, please sit. So when you are giving the IV infusion, based on the patient's blood pressure monitoring, you will have to titrate the rate of the drip. Okay, you cannot allow the BP to just shoot up like this. Okay, you have to, what he said is very right, that is titrating the patient's blood pressure level to see to it that it suddenly doesn't rise. And based on the patient's response to the noradrenaline, we will have to titrate the dose so that the blood pressure just doesn't shoot up all of a sudden. So that is very important. So tomorrow when you all become interns, okay, and when you are asked to give noradrenaline and further in your clinical practice, this is something which you have to keep in mind. So certain extra points as it was told during the lecture. So during the lecture we did tell you all, as one of you all did point out, that is Bala pointed out, that is during the injection, okay, like I was telling you, during IV injection there can be extravasation of the drug leading to local vasospasm, ischemia and intense pain. But in this situation, IM injection has caused ischemia and intense pain. So best is we avoid the IM injection. And another, as we have seen here, marked rise in the blood pressure leading to cerebral hemorrhage and development of hemiplegia. And another, the basis of all this you will understand if you understand the effect of, as it has been given in your books, which this table was put up during the lecture, this picture, that is adrenaline, noradrenaline and isoprenalin, which exactly adrenergic receptors are these drugs acting on. So this background knowledge is very important for you to know which receptors they are acting on, where these receptors are located. So exactly you will be able to understand how they produce their various pharmacological actions and adverse effects. And in the lecture, I remember I had very clearly told you that is noradrenaline is acting on all the adrenergic receptors except beta 2. It is not acting on beta 2. Beta 2, as you know, they are present on the blood vessels, they are present in the bronchial smooth muscle, on the uterus and all that, but noradrenaline has no beta 2 action. Okay, so it produces action on all the adrenergic receptors except for beta 2. So that is to be kept in mind. Now, if I think we are clear with all this, if any one of you has any doubts, any clarifications, you can stand up and ask me. Okay, so if you don't, then we can move on to the next case. Now you can see the case, or you can see what I have projected here. That is, there is a patient with acute attack of glaucoma. He is being treated with certain eye drops. Now patient complains of severe brow pain and his vision is fixed to near objects. So the questions which you need to answer, that is now to just give you all a background. Treatment of glaucoma and pharmacotherapy of glaucoma was a part of the lecture on beta blockers, and also before that, when we were dealing with other classes of drugs acting on ALS, we dealt with some of those drugs which have an effect on the treatment of patients with glaucoma. So we stated that using the resources and the previous lectures that you have attended, so you will be able to answer these questions. So in this particular patient, which drug do you think might have been used topically based on what all the patient has now developed? That is, he has developed severe brow pain. Arun, you are not supposed to talk before I finish reading the case. So what systemic effects do you expect if this drug is absorbed into the circulation, and enumerate other drugs used for the treatment of acute angle closure glaucoma? Why, Swarupa, you were in such a hurry to start? Now you can start discussing the case now that I have finished reading everything. Okay, I expect you all to maintain a certain level of discipline in the class that I have told you all. I don't like it when people interrupt me when I am reading. You can take your time. You can take about 2 minutes. If you are ready, you can tell me. I hope you all are seriously discussing only the subject and nothing else. So shall we start? Okay. to tell, that is, which drug or class of drugs do you think might have been instilled topically? Yes, Varupa?
Cholinergic drugs like pilocarpine,
Yes, or
physostigmine.
5-cysteine. Very good. So she is right. But based on what evidence did you say that these drugs are cholinergic drugs? How did you come to the conclusion that these drugs are cholinergic drugs? Is there any clue in the case which tells you?
The vigilance surface.
Yes, very good. Yes, very good. That is one clue.
Myotics tend to cause brow ache.
Yes, very good. So she is right. That is severe brow ache and vision being fixed for near vision. They are two clues which tell you that the drug instilled may have been a myotic, that is specifically a cholinergic drugs. That is your pilocarpine or your physostigmine. Now, what systemic effects do you expect if this drug gets absorbed into the circulation? So, who will volunteer? Yes, Afra?
Because they are cholinergic, so there will be excessive secretions.
Yes, very good. Sweating.
Sweating, diarrhea, and
Sweating and diarrhea, yes.
bronchospasm.
Bronchospasm, very good. So, please sit. So, sweating, lacrimation, bronchospasm, diarrhea, these could be the possible effects following systemic absorption of the drug. So, now this patient has come with acute angle closure glaucoma. So, what do you think are the other classes of drugs which are used? Actually, those classes they should be used before myotics. So, which are those?
First we can use carbonic anhydrase
Yes,
inhibitors.
carbonic anhydrase inhibitors, for example,
Acetazolamide.
acetazolamide, very good. Anything else? Not prostaglandin analogs. Okay, but before that? No? Yes, very good. Very good. Mannitol, that is what we call your osmotic diuretic. So, osmotic diuretic, that is IV mannitol followed by IV carbonic anhydrase inhibitor, that is acetazolamide. After lowering the blood, the intraocular pressure with these agents initially, then it is myotic is warranted. Giving a myotic first itself, the eye may not respond. Okay, so you have to initially bring down the intraocular pressure using mannitol, using acetazolamide. Following that, we instill myotic. So to just continue and elaborate on what was told by your friends, that is, of course, one is, you can see when we were telling you all about the class on beta blockers, what advantages they have, meaning this tells us the drawbacks of myotics. So drawbacks of myotics, they have said here that there is brow pain and headache, which is not seen with topical beta blockers. So as Swarupa said, brow pain and headache is being produced by these myotics, and that gave her the clue to say that yes, a cholinergic drug has been instilled, because cholinergic drugs, they produce a spasm of the iris, that is sphincter pupillae, and they also cause spasm of the ciliary muscles. So because of that, this patient has developed a headache and brow pain. That is one thing. And another, she I think told us about this change in the pupillary size and spasm of accommodation, vision being fixed for near vision. Okay, so that again is not seen with beta blockers, but it is seen with myotics. Now see here, the diagram here is telling you the action of the myotics, which we had told you. So just to reiterate that, now if any one of you all can remember, where do myotics, these cholinergics, act to produce their effect in glaucoma? Yes, so one is they are contracting the iris by causing contraction of the sphincter pupillae. So the iris is more in the center, and this you can see this is the iridocorneal angle. So when the sphincter pupillae contracts, iris moves more towards the center, and it helps in the effective drainage of aqueous through the trabecular meshwork. So helps in better drainage of aqueous, because the iris, after it has contracted, it will help in removing this what we call iridocorneal angle block also is the angle becomes more wide. Here it is a case of acute angle closure glaucoma where the angle has been obliterated or it has become very narrow for the aqueous to flow out. So now the angle, once it becomes wide, it becomes easier for the aqueous to drain out from the eye into the plasma. That is one. And another thing is, what about the Swarupa said about spasm of accommodation. So why do you think now that has happened?
Compression of ciliary.
Yes, very good. So one more, see here in the diagram you can see there are two effects of this. One is, as Varun said, on the iris sphincter pupillae. Apart from that, as he said now, the action on the ciliary muscle. Can you see the pointer here? Ciliary muscle. Okay, maybe I will have to use a laser pointer. So here, as you can see, one is the effect of the iris I told you and causing this angle to open up fully. And apart from that, I told you the action on the ciliary muscle. So this effect on the ciliary muscle is causing the ciliary muscle becomes taut. As a result, the suspensory ligament of the lens. So here you can see this is the suspensory ligament of the lens. So the suspensory ligament becomes lax. So here you can see as shown in this other diagram. So here you can see ciliary muscle has contracted, the suspensory ligament has become relaxed, and you can see the lens has moved closer to the cornea. Means it is moving more, it is bulging into the anterior chamber. As compared to this, here you can see there is no such problem, whereas here you can see when the miotic has acted, ciliary muscle contracted, relaxation of the suspensory ligament, and lens having moved more into the anterior chamber or bulging into the anterior chamber, and the focal length of the lens changes and the vision is fixed for near vision, what we call spasm of accommodation. So it has been given in this case that you can see in the case it has been mentioned his vision is fixed for near vision. So spasm of accommodation. Okay. So I think now these two cases we have made it clear to you all, and you all have shown the ability of good correlation of your theoretical knowledge with the ability to correlate that to clinical scenarios which are given. So that's really nice because you will be coming across such clinical scenarios in your internship as well as in your practice here further. So using these clinical scenarios, we have sensitized you all to how to think like a clinician. Okay, so similar case scenarios will be given to you all during your practical examination, both in your sessional as well as your university examinations, that is during your both formative as well as summative assessment. So I think now you will be able to tackle those scenarios well. Okay, and I think the case-based learning session has gone quite well. But if any of you has any doubt, any clarification right now, you can please stand up and you can voice your queries, your clarifications if any. Otherwise, I think we can close this today's case-based learning session. So I thank all of you all for being good audience and for having participated actively in this session.